right. Hello. Good evening or good afternoon, good morning, depending on when you're tuning in from. Thank you again for joining another one of our NSWOCC and WOC Institute continuing educational webinars. Today we have a fantastic guest speaker with us today, Stephanie Constable. But before I introduce Stephanie, I want to do a couple little housekeeping items and briefly introduce what we're going to be talking about today. So first things first, my name's Troy. I'm the Chief Operating Officer with Nurses Specialized in Wound, Ostomy, and Continence Canada. And I'm very pleased to welcome you again, as I said today. I see people are already clicking on that chat button, but my next thing to do is ask all of you to click on your chat button in your Zoom toolbar and just introduce yourself. Maybe let us know where you're tuning in from, maybe what your role in wound care or pressure injury prevention might be, what kind of area across the continuum of care you might work in. It's nice to see we've got Amherst, we've got Regina, we've got Clavit, we got Thunder Bay, we got people from all over. So thanks for joining us. We're going to be talking about building an effective pressure injury prevention protocol, understanding the risks, impact, and implementation today. And we're going to be recording today's session. So if you have to head out early, or if you know a colleague of yours that might benefit from watching this, you're going to be able to watch it again on demand on our website at nswoc.ca. Just give us about a day or two to get that edited and up there for you. All those who are online today, you're going to be receiving a certificate of attendance as well. And same with the recording, just give us about a day or two to get those into your email inboxes. We're also going to be doing a Q&A session at the end. So if you have questions for myself or Stephanie or Smith and Nephew during this presentation, please use the Q&A function in Zoom. So not the chat that you're using right now, but click on that Q&A toolbar button and ask as many questions as you like. That'll keep it organized for us and we can get to as many as possible at the end. I mentioned Smith and Nephew there, and we want to thank them so much for making today's education possible. We really appreciate their support. And so the one of many webinars we often do with Smith and Nephew throughout the year. So thank you again to Smith and Nephew for making it possible today. So without further ado, I'm really happy to introduce Stephanie. Stephanie Constable is a BSN prepared registered nurse and a certified wound, ostomy, and continence nurse based at United Hospital Center in Bridgeport, West Virginia, where she serves as the sole WOC nurse there. She brings extensive clinical and leadership experience, including her role as chair at her hospital's Pressure Injury Prevention Committee. In addition to her clinical work, Stephanie is actively involved in patient safety, infection control, and quality improvement initiatives, including root cause analysis and chart reviews. She's presented internationally, including at the EPUAP conference in 2024 and at WOC Next last year in 2025, where she shared her team's success in reducing hospital-acquired pressure injuries. She's also contributing to the development of the upcoming National Pressure Injury Advisory Panel guidelines on prevention and treatment. Stephanie's truly passionate about improving patient outcomes through prevention and evidence-based care, and we are so pleased to have you with us today to share your experience, your tips, and your guidance. So thank you so much, Stephanie, for being with us.
Thank you for having me. Hi, everybody. I'm excited to be here. I want to preface the previous presentation with letting everybody know that I am at home. I've never done one from home, so it could be interesting. I convinced my husband to take the girls out for dinner. However, my youngest has no chill and she's pretty feral. So if they make it home before the end of our presentation, there's a chance that you might hear them. So hopefully not, but I at least want to put that out there ahead of time. But thank you guys for joining me for building an effective pressure injury prevention protocol, understanding risks, impacts, and implementations. This is my disclaimer slide. So this presentation is for educational purposes only. All of the opinions and outcomes that are shared in this presentation are my own, but for the purpose of this presentation, I am a paid presenter for Smith Nephew. It's my background. So that's my lovely hospital. It's United Hospital Center. It's part of WV Medicine. We have about 30 hospitals now. I swear we keep growing every time I turn around. I have my bachelor's. I'm the sole specialist for 330 beds. Same thing. We keep growing. I think just last year we were only 2 years ago, we were 285, and then we were 310, and now we're at 330, and we're building a surgery center, and we're finally might add a second person. So I have to admit, I'm pretty excited about that. But I've been here for 13 years in this role, 15 years total. Prevention is definitely my passion. Most of the things that I work on or present on and share on are on prevention. I obviously do all things wound care, but I do love to talk about pressure injury prevention and the impacts that it has on patients. Some of the things that I've done. So we're still working. It says 2025 NPIP guidelines. However, it's taken us a little bit longer, so it's still in the works, but I am on the panel to release those guidelines for the US. They'll be active for the next 5 years, I believe. I sat on a global pressure injury advisory council. One of the things that I loved about doing that was there was 20 to 25 of us all over the world, and it was kind of mind-boggling that we all had the same problems. So it's very interesting that this is not just a US or a Canada or a UK. It's a problem everywhere, and we're definitely working to fix it and come up with interventions that will work for everybody. I'm the chair for my hospital's pressure injury prevention committee, and I also sit on our system pressure injury prevention committee for those 30 hospitals. Our learning objectives for today are to assess the negative patient outcomes, including prolonged length of stay, physical discomfort, and emotional distress, review the impacts on healthcare providers, such as increased workload, stress, and liability concerns, describe the data collection process to identify gaps, trends, and pressure injury related issues. Identify key stakeholders, including patients, nursing staff, organizational leadership, and supply partners, and to evaluate and consider potential solutions, including product trials and evidence-based interventions. So we'll start off simple. What is a pressure injury? So a pressure injury is a localized area of damage to the skin or underlying soft tissue. It's usually located over a bony prominence, but more recently we've talked about the incidence rate of medical device injuries. So it can also be related to a medical or other device, resulting from intense and prolonged pressure in combination with shear. The injury can present as intact skin or an open ulcer, and it can often be painful. So my question was, which of these pressure injuries or which of these injuries were pressure? Obviously, they are all pressure. So it's kind of a cheat question, but I think it's important to look at all of these and see how different they are. So you have stage fours that have a lot of exposed structures underneath. You have one that's intact, a deep tissue injury, still has the overlying skin intact, an unstageable that looks like the overlying tissue's intact, but it's necrotic. So we know that there's going to be more and more tissue loss associated with that. And then one that's full thickness, however, there's not a lot of depth to it. So the thing that I think is important when looking at these and talking about staging is to understand that the physical depth of the wound does not determine the stage. So these can all differ based on the location of the body and the patient's body habitus. So this one down here that doesn't have a lot of depth, it's still a stage 3. It's a full thickness injury. However, the one way up at the top, it's a stage 4, obviously, which is still also full thickness, but with underlying structures exposed. So staging can be hard. One of the things we've learned at our facility, I think it's funny that there's so many things that have textbook definitions, and pressure injuries is one of them. However, it seems that we still struggle with identifying the correct staging for pressure injuries. So it's really important that this education piece be out there to your staff, and then we understand that the physical depth of the wound is not always correlate with what the stage is. It has to also include the location, the amount of tissue loss. Every patient's different. This is another one, and this is something I talked about with our coding department. It's really important that we be able to differentiate other common etiologies that we see. So it's important that nursing understands, but it's also really important that our clinicians understand, because a lot of times the coding or the actual diagnosis of the wound that comes from the physicians, that doesn't come from the bedside nurse. So obviously we want our bedside nurses to be able to identify etiologies just because that helps us get the appropriate treatment started sooner. But it's also really important that this education be done with our physicians, our clinicians, our advanced practice providers, and even our coding. I've worked with our coding a good bit. So some of the things you see here is skin tear up in the top left, some diabetic foot ulcers. A lot of times it's pretty common to see callus formation around those wounds from the repetitive injury. And then the two on the left-hand side there are moisture-associated skin damage. And that's one that there's a lot of times, not overlap, but I'd say that's the most common misdiagnosis between pressure injury and moisture-associated skin damage. Pressure injury development. So There are multiple factors that can play into the development of a pressure injury: pressure, shear, friction, microclimate. All of these different sources of damage can cause wounds on their own, but a lot of times you'll see them combined or overlapping. And definitely when it relates to a pressure injury, when somebody has a lot of moisture, their skin is more susceptible to pressure damage or friction damage. So it's important to keep in mind that it's not just pressure that affects or makes these patients at risk. So the two most common ways or two ways damage occur are cell deformation and tissue ischemia. Cell deformation. So I want you to think about large amounts of damage. So a lot of times, an easy one to think about is deep tissue injury. We know that a deep tissue injury is damage that occurs to the underlying layers. A lot of times we say it's like a triangle. So the damage that you see on top is usually a lot worse underneath. So when that damage occurs deep in the layers, you have deformation of the cell and then disruption of the cytoskeleton. The cell membrane fails, which increases the permeability, the loss of hemostasis, and then the cell dies. So ultimately, that cell death is what causes the continual breakdown of tissue or tissue loss. Let's see, I have a little video here. Let's play.
Pressure injuries often occur around bony prominences, such as the sacrum, heel, or underneath medical devices. Pressure injuries are areas of localized damage to the skin and underlying tissue, often impacting patients with limited mobility. This is the result of sustained soft tissue deformations caused by pressure in combination with shear being applied to the skin. Shear is a surface force with parallel motion, causing layers of skin to slide against each other, resulting in deep tissue damage. Friction is the resistance that occurs when the skin is dragged across a surface, contributing to shear forces within underlying tissues.
Okay, so similar to what I just said, however, so for some reason I feel like her voice is way more soothing than mine. Just sounds more soothing. So again, it's that combination of all of these different forces. I like the beginning of the video because it shows your highest risk areas: the heels, the sacrum, the coccyx, elbows, anywhere that touches the surface most frequently, but also has a smaller amount of fat or subcutaneous tissue, those layers in between your bone and the skin surface. It's a cell deformation pictures over here. So although we don't think of it this way, when we have a lot of pressure on the overlying skin and soft tissue, it kind of smushes the cells in there. And at the very minimal or easiest way to think about it, when you have a bunch of the top picture where the cells are all, they have breathing room and they have room to move. And when you're sliding a patient in bed, those areas are able to more easily slide against each other without causing damage to the cells. When you have them all really squished together and then you kind of slide them, it's a lot more likely that you're going to cause damage to those underlying tissue, cells and tissue, resulting in the pressure injuries.
Pressure injury.
Oh, I have no idea what to play it again. Sorry. So the other mechanism of action or mechanism that can cause cell death is tissue ischemia. So for this one, I always think of a patient that comes in with sepsis. It's easier for me to think of an actual patient situation. So a patient that comes in with sepsis and we put them on vasopressors. That feels like a pretty common occurrence at our facility. I don't know if it's for everybody else, but for us. So whenever you put somebody on, they're septic and we put them on vasopressors, the goal is to constrict the vessels to shunt the largest amount of blood to the vital organs. So the skin is not considered a vital organ in that situation. So you have a reduction in the blood flow to this huge organ that we're looking at as not as important as the rest. And in some situations, I understand that. However, it can often create these pressure injuries that even after we save them, now we have this long-lasting impact. So whenever this happens, you have the impaired perfusion, reduced oxygenation, metabolism changes, waste accumulates, the pH decreases, and the cell dies. So in both situations, the end result is that the cell dies. And when those cells die, that's where you start to see sloughing or breakdown of the tissue that results in that open wound or damage to the tissue there. So question, when a patient develops a pressure injury, do you know how their length of stay is affected? I always like this slide. When a patient develops a pressure injury while hospitalized for another condition, it's more likely that one, they'll require readmission. So when the patient has a wound, I've actually can think of several off the top of my head that we might save them or heal them from the problem they came in with. But when they leave with this hospital-acquired pressure injury, they come back for debridement or for wound infection or for several different things that require a readmission. The financial burden, that's probably the most common talked about thing. This number probably changes, I wouldn't say year to year, but every time we reevaluate the impact. But no matter what, at the end of the day, there is a financial impact. So it's definitely important to consider. The average length of stay or days in the bed increases to 9.5 when they have a greater or when they have a hospital-acquired pressure injury. Now, this one I added for me. So the one before is obviously important. We always want to understand that there is the risk of readmission that takes up a hospital bed, and now another patient doesn't have a bed and the financial impact. But one of the things that I feel like, not that it gets missed, but is so important is the emotional and mental impact that this has on the actual patient. So consider what burden this has. When you think about a patient is staying in the hospital 9.5 days longer. So that's 9.5 days that they are away from their family, away from their friends, away from their pets, that they're not able to meet their responsibilities, such as paying bills or caring for their home. All of these different things really impact the patient's mental or emotional well-being. And I think sometimes as organizations, we don't, obviously we're aware that it's a problem for the patient or there's implications to the patient, but I think sometimes we don't really think about what those are. So one of the things that I've really brought to the bedside over the last couple of years is really thinking about or showcasing to them what the actual physical impact to this patient is outside of the financial piece of it. Are you aware of the physical, emotional, and financial impacts of pressure injuries in your organization? So I think it's important to understand that pressure injuries not only impact the patient, of course, that's the most, I don't want to say most important, but it's the biggest implication is when it occurs to the patient and the pain and the stress and all of these different things you put the patient through. But it also impacts the providers and the organization as well, not just financially. So when you look at these pictures over here, look at the bottom picture. That's obviously somebody's intact skin. I know it looks kind of funny when you think about it. You wouldn't think you'd see that picture on here, but I want you to look at all three of them and think about the time or effort that it goes into caring for that bottom picture, which is none. And then think about the time, effort, impact that it goes into caring for these top two pictures. So when a patient, not only do you have the lack of trust or frustration that you often see from the patients. Whenever a patient comes in for one condition and they leave with another problem, I'm sure anybody could understand why that would be frustrating. But it also creates some mistrust. I came in here to be cared for, and now I left with another problem that I have to deal with for who knows how long. Obviously, there's the monetary impact, but think about the time that it takes. So if you discharge a patient with their intact skin, they go home. And, that's the end of it. They might have a 3 month, 6 month, whatever follow up with their provider. If they leave with a wound, now you not only have to consider that they might need home care services, nursing home care services, that is a financial implication, but also a time implication. The time that it takes for the providers to reassess the wound on an ongoing basis and create that treatment plan, adjust it as needed, make sure that they get the products. Are they able to afford the products? Do their insurance cover them? So then you include not only you, the nurse that's caring for it, the clinician that's creating, evaluating, developing this treatment plan, social work, or whoever might be working with them to make sure they can get the products that they need. There's so many different pieces that go into that. It can create a lot of additional stress on an organization outside of just the financial impact. So how do we identify the problem? Identifying the problems, data is the biggest, and I don't want to say easiest because it's not easy, but It's the number one common language. So whenever I used to go to some of our committees, I can talk about, this number, that number. Um, Everybody can speak to data. Everybody can look at numbers and understand. So I found that that is one of the easiest ways to communicate a problem, to identify a problem, and it helps to support the problem that you're working towards fixing. So if you can show, hey, if you say we have a pressure injury problem, what does that mean to anybody outside of you? It's not going to mean the same thing to anybody. But when you go and you say, this year we had three, or, last year we had three, and this year we have 20, that's a big change. So being able to actually quote the numbers, show the data, it's very supportive of your goals. How do you determine what changes could be most effective in solving your problems? Evidence-based practice and data. So you obviously want to don't do all the work yourself. Other people have already done a lot of the work. So look to what other people have done and what has been successful. I wish I had done that a little more in the beginning. I definitely do that now because in the beginning, I just didn't know how to do that or that I should do that or where to look for that. But now that I've spent a lot of blood, sweat, and tears figuring it out, I also understand that I'm not the only one. So looking for that evidence-based practice of what other people can prove have worked for them is huge. And then your own data. So showing that, hey, we changed this and now our rate is this. So if I'm being honest, when I first started tracking my data, I had no idea what I was going to do with it. I only did it. This is always funny. I only did it because the person before me did it. I didn't have some grand plan or I thought, I know exactly how this is going to help me. Not at all. So, luckily I did. And about 3 years into it, I started using it for little things. Now 13 years later, I have a big pool of data and it has really helped me make some great changes in my facility. How do you prove the changes you have implemented are successful? Like I said, data. So two kind of short, specific scenarios where data helped me fix a problem. So we saw an uptick in sacral hospital-acquired pressure injuries. And once we looked into those individual cases, we found that there was a large portion of them that were hip fracture patients. And the time frame that they were developing them was shortly after surgery. So our theory, or based on the data and research, was that the fracture table that was being used in the OR for this specific procedure, it's a very interesting one if nobody's ever seen it, but it was, contributing to these pressure injuries. So we created the policy or process that every patient before they went onto that procedure table got a preventative foam to their sacrum, and it decreased the number of sacral pressure injuries. Same thing for the heel. We were seeing a lot of heel pressure injuries in femur fracture patients. And if you've never treated a patient with a femur fracture, we were seeing a little bit of both. So the leg that had the fracture is obviously immobile. They're having a lot of pain. They're not supposed to move it. They're in maybe, I don't know, traction, whatever the reason is. So that leg is very immobile, which increases the risk. But then we also found that they were overutilizing their other heel and using it to push off in the bed. So increasing the friction shearing damage to that heel. So we automatically created kind of a process that every patient that came in with the diagnosis of a femur fracture got heel preventative dressings or heel offloading devices, just depending on the patient scenario. However, some kind of heel pressure injury prevention intervention for those patients, and it decreased that number. So those were two ways that we used the data, figured out what we thought the problem was, came up with an intervention, and then we're able to prove that our intervention worked. What data is gathered to identify gaps? So I know I talked about that a little bit, I gave two scenarios, but a couple of the other pieces that I've used or begun using over the years. So knowing what your pressure injury prevalence is important because it kind of goes hand in hand with your pressure injury incidence. So your pressure injury prevalence is knowing how many patients in your organization or that are admitted are diagnosed with a pressure injury and comparing that to the number of total patients admitted that year. So how many patients in that year had a pressure injury and how many total did you have? This is really reliant on accurate diagnosis and coding because obviously as wound care specialists, I don't know how many you have in your facility. I can't see every person, and I'm sure that it's the same for you guys. So it's kind of impossible. So working with your coding and your clinicians, like I mentioned earlier, it's really important that they understand and that they are diagnosing correctly for you to be able to accurately identify and come up with these numbers. So pressure injury incidents, that's the number of hospital-acquired pressure injuries compared to, the total number of patients. So obviously you want that number to be a whole lot less than your prevalence level. I don't know if this is everywhere, but there's a lot of organizations that grade hospitals out there. And truly, I have had patients tell me that they look at the grade of the hospital, which is based on the number of, hospital acquired conditions. Those rates factor into that they check the grades of the hospital before they seek service there, which I'm not saying that is absolutely within their rights. And I understand that, but I was still surprised. Like I guess I didn't know that we graded hospitals or, things like that. And it just makes it even more important because sometimes, it can be misguiding or misleading. If we're not paying attention to one specific condition and we're not treating it maybe as thoroughly as we should, it can really give the overall organization a bad look or create mistrust within patients within the community. You can look at your, sorry, advanced wound care spend, support surface spend, amount of time the specialist spends on this patient population compared to others, and then patient acuity, which this can be difficult. So I've gotten a little creative with finding it. We use acuity tools in our facility, but it's really difficult. It's kind of like not everybody uses them appropriately, so it's not something I totally relied on. So I'll show in the next slide how I started tracking acuity levels. So I'm currently in my master's program. I'm doing nursing informatics, and I do all kinds of, I don't know, creating different ways to display data. So when a lot of people look at this, or when I look at other people's data, they're just numbers to me. But when you create something like this and you're tracking your own data, it tells a story. So I can look at this, this bar graph here, and I can tell you that I started in 2013. And I was like, okay, our numbers from 2012 were kind of high. So I implemented a pressure injury prevention team from 2013 to 2014, and that was effective. And you can see our numbers went down. And then in 2016, our numbers went up. So, with leading into that year, we redid education, we rebolstered our team, all the things that I knew to do as a baby clinician. I still call myself. I don't know that I was faking it till I made it at that point, I think. But I did everything that I knew to do. So it was just kind of a fluke a little bit that somebody came in and said, "Do you want to try this other preventative foam dressing?" And I thought, what's it going to hurt at that point? So we did, and you can see that our numbers slowly began to decrease. In 2019, that was where we started tracking our long-term care numbers. So you can see an increase, but it's important to know that because if if somebody else was just looking at that, it looks like our numbers increased and we should be looking for a cause within our facility instead of knowing that, oh, we just added more people to look at. And then in 2022, so we systemized around 2020, and over those 2 years, part of it was COVID and trying to drive down costs and combine resources and things like that. But the skincare contract came up, and in 2022, they systemized to another product, and you can see how high that number went for us. And then after we saw that big of an increase in hospital-acquired pressure injuries, and that's just ours, there was an increase across our entire system. Everybody saw it, so we switched away from that preventative dressing, and we switched back to the one that we used earlier in 2017 and 18. And then in 2023, you can see this is where we implemented a repositioning reminder system, but our numbers were still a little higher compared to when we were using the product the first time, when we were using it the second time. And I kept saying, I don't know how to prove it, but I feel like our patients are just sicker. So the only way I could come up with, and this doesn't mean that this is correct or there might be a better way, but was to start tracking ventilator days. So I started tracking, that's what the orange line is there, the number of ventilator days. So it shows that, in 2018, we had 1,000 less days than we did in 2023. So our patients were a lot less sick back then. So even though we're using the same product, our patients are sicker, which obviously would increase the risk of them developing a pressure injury. How do you measure improvement? And this is not, again, same thing, not an end all be all. There are plenty of ways to measure the way that your facility improves. I feel like they all should surround around data or different things similar, but this was just a way that I chose to do it. So we used the resource down below to show, what the cost of a pressure injury was. But this will change. So if you decide to do something like this, you should always look for the most recent data you can find on what they estimate the cost of each pressure injury cost. So the periods are broken up, you can see on the right-hand side, to the products that we use. So dressing one, dressing two, dressing three, which I'm sure everybody can guess was that system change that we had. And then dressing three with the repositioning reminder system, which this was a very small period of time. And then dressing two with the repositioning reminder system. So what I did was track the number of pressure injuries that occurred during each of these periods and then multiplied with the stages by the estimated cost of the stage, just to kind of show what were these hospital-acquired pressure injuries costing us compared, or coinciding with what products we were utilizing. So that worked for us. There are plenty of different ways you can utilize that data out there, but that was one that worked for us. So how do we create organizational best practice? There's multiple factors in creating this best practice: leadership commitment, a multidisciplinary team. So it's important to understand that pressure injuries are not just a nursing problem, it is an organizational problem. Unit-based skin teams, having people that are experts or knowledgeable at the bedside is so important. What your processes are, do they align with best practice, and your product selection? Leadership commitment. Changing the practice and mindset of a facility is no easy task. In the early phases, identifying your key stakeholders and determining why this change should be important to them will set the stage for overall success. This is so true. Truly, when we implemented one of our changes, which was the repositioning reminder system, I was so fortunate. I went to the first meeting that I had to have, and I felt like I was in a tank of sharks, and it was terrifying. And I went to our CNO and I said, "The next time you were going with me," and I had her backing, and they didn't push as hard, and I felt like people really listen more, and that might just be my perception, but my point is that having that leadership commitment or acknowledgement of what the problem is and committing to fixing it is so important because we can't fix problems individually. It has to be as an organization as a whole. So some of the other key stakeholders, in my opinion, are obviously the nursing leadership, your wound care leaders, because I was just joking earlier, like I will never use the word expert, but I do feel that I have more knowledge about wound care processes than people in our facility who don't specialize in wound care. So being that leader for your organization, your bedside nurses, because if it does not work for the bedside nurse, then you're never going to be successful. So working together and creating processes that work for them and getting them to buy into your process is imperative. Quality improvement and risk management, they're very supportive in helping you identify that you have a problem and maybe what some factors that go into that problem are and helping you fix them. Financial, everything. I say this, at the end of the day, hospitals are a business. So we're always looking at that finance piece too. The legal department, I don't know if it's the same for you, but in the US, we discussed that hospital-acquired pressure injuries are one of the most highly litigated cases, one of the most highly litigated conditions that we see and very costly. So, I mean, rightfully so. It should never have to happen, and we never want to see something happen to a patient that occurred in our organization. But same thing, it's also a very high risk situation to your organization legal wise. And then product purchasing and distribution. What makes pressure injury prevention multidisciplinary? How do you ensure your staff are consistently implementing preventative strategies? So, like I said before, pressure injury prevention or pressure injury development is not just a nursing problem. We have to involve all of the different specialties. So like I said, the bedside nursing, they care for the patients. Physical therapy, they get our patients up and they walk them. Sometimes they see their skin before the nurse even does. Dietitians are responsible for optimizing their nutritional outcomes. The physicians are responsible for managing the treatment plans. If they're not aware of what the best practices are or what the products are, then how can they be expected to create the best or optimal treatment plan? And then quality improvement members, like I said, they can help you identify what your problems are and ways that you can fix them. So some of the responsibilities or things that occur with our multidisciplinary team are education. We educate the team. We do organizational prevalence studies, data and root cause analysis, opportunities for improvement, and implement education throughout the hospital. So it's important, like I said, we educate our multidisciplinary team. So there are champions. They're the ones that we are expecting to roll the education out to all the other members of our hospital or to be support for them. However, creating an education program that combines, sometimes for ours, this is a true example of our program. We combined didactic and the hands-on experience, and we opened it to everybody every nurse in our facility. Because the more nurses that you have that have some knowledge, experience, the more overall success you will see. So obviously, it's important to have those unit-based team members to really be your champions. But when you have an increase in the knowledge in your organization as a whole, it's going to improve your outcomes. Some of the things, the hands-on stations we included were actual staging, the repositioning reminder system, the turning and repositioning device that we use, advanced wound care products, and negative pressure wound therapy. So I think didactic is huge. It's very important. We talked about, staging, what a hospital-acquired pressure injury, what the opportunity for improvement was. But letting them truly get their hands on the products and ask questions in a situation that was not as high stress and they didn't feel the need to perform, it really opened up the communication and allowed for those questions to be asked and that knowledge to be gained. So it really made a big difference. And I encourage you to create some kind of program like that for your staff. Root cause analysis was probably one of the unknowingly most important processes that we create in our facility. And I say unknowingly, not that I don't think that there's obviously a benefit to identifying the root cause of a problem. But if I'm being completely transparent, which I usually am, I was a little frustrated when they wanted to create this process. And I was like, I don't have time to do that. And, why do I have to, why is this not quality? Why is it wound care? And it's a combination, but it's truly changed the way that the conversations that we have about pressure injuries. And it's made such a difference in actually fixing the organizational problem. So, every time a pressure injury develops, we look at the chart and I look at the chart and I look for what's the information about that hospital-acquired pressure injury. Did they turn and reposition that patient? What was their nutritional intake? Did they implement the preventative measures that they should? If they did they do it when they should have? Was there a delay? What was the nursing's documentation? So it's important to look, was the patient combative? Did the patient refuse? There are definitely factors that go into your nurse can't change those. So your bedside nurse can do all the right things. And if the patient refuses, it's that patient's right. So looking at their documentation is important. What did the physician order? What were their labs, comorbidities, past medical history? After I complete all that, I send out a form I usually identify a time frame of when I think that pressure injury developed based on evidence-based practice. And I have the staff that cared for that patient during that time frame complete a form, and it regards the patient's condition at the time they cared for them. And then after they complete all those, we come together in a formal meeting. And usually we have me and risk, safety, quality, unit leadership, and then the bedside nurses that care for that patient. And if I'm being honest, the that formal meeting is sometimes the most important part. All of it's important. I've definitely found things like, oh, we didn't implement this when we should have, or, oh, the patient refused. It was adequately documented. There was nothing else we could have done. But a lot of times in those formal meetings, things will come out in discussion that weren't part of the paper, weren't part of my chart review that were, I'm saying enlightening, but definitely to where it was like that was not even something I considered adding on there. And we fixed the process just because we had a really good, honest conversation. So this process was really huge for us. And then after you do the root cause analysis process, then you create opportunities for improvement. So again, you're having that conversation, you're identifying, okay, where did we fail? And when I say fail, it sounds like such a negative word, but not always. So sometimes it is that a person failed, person just didn't do what they should do. But honestly, most of the time, that's not the case. A lot of times, it's our process failed, our product failed. There was a miscommunication, lack of documentation. There's so many different things that can come from it. And then you have to create, or we create, how are we going to correct this or decrease the chance that it's going to happen again in the future? So, our typical corrective action plans are the ones we see the most. I would say are individual interventions. So, I wouldn't even say that we see that the most, but if we see it to where we see, okay, we have a repeat offender, or we just have a nurse that maybe didn't understand, like based on what they documented, we find they just didn't understand the process. Then it's individual one-on-one. Okay, show me what you're doing. Tell me what your thoughts are. And then you have sometimes just a process is wrong on a unit. So unit-based education, organizational change, hospital-wide education. Okay, we're all doing it wrong. Policy or process change, unit or organizational audits, and then a product change. So sometimes it is just a product. The product's a fail. It doesn't work. It's not effective. One of the things we find, if I'm being truly honest, one of the biggest things is accountability. So those unit or organizational audits, everybody hates them, but they are so effective because truly, until you can hold people accountable to the job or the process or the whatever it is that you're asking them to do, it's really difficult to ensure that they are. So when you come out with audits of some type, there's many different kinds that you can just spot check. Are they, is this patient at risk and was the stuff ordered? It's just a simple way to put it. But when you start holding people accountable, you find that they do it a lot more on their own once they know they're going to be held accountable for it. Unit-based skin teams. So this is, again, I know I've talked about it a little bit, but so important because these are the people that are at the bedside. So they're working alongside all the other bedside nurses. And I've always said, when I do product trials or things like that, I let the bedside nurses trial it. Of course, I give my input to make sure that the product is something that is um, not adequate, but that should be used in that situation. But then I let the bedside nurses try it because at the end of the day, they're the ones that are using it. So I can say this is a great product, but if in the situation of patient use it doesn't work, then it's almost doesn't matter. So I always want to make sure that the product or processes that I implement or change are working for the bedside nurses. So it's having having that representation on your multidisciplinary team is imperative. They provide education to their other team members. And the most important thing is they identify those problems. So not only do they do that one-on-one, they also bring back to our committee problems that I'm only one person. So I can't be in all 330 rooms every day to see what might be a problem. So I rely on those skin team members to tell me what things are or aren't working on their unit. They can carry out those corrective action plan audits. Sometimes it's nursing leadership on the unit, sometimes the skincare team helps. And then also, this is just kind of an afterthought, but they can also be the stagers. One of the things we do, some facilities take staging away from bedside nurses completely, and that's just unrealistic for us because there's one of me and I can't see them all. So we created stagers, which is our skin team members, so that then, the bedside nurse does the rest of the assessment for the wound, and then a stager stages it. So that's just another way they can be utilized. Patient-specific best practices, so use of a validated PI risk assessment tool to reassess as indicated. Performing the skin assessment shift and daily. This is important. The piece that I want to point out is this should be done on every patient, not just on every patient that seems at risk, because a couple times we have found that a patient is a walkie-talkie and somebody decides to look at their coccyx on day 3 and they have a pressure injury. And then when I go back and ask, well, they were walking and talking. I didn't want to ask them to look at their butt. That's not, we have to, we have to look at all these patients. It's our job to assess their skin every day, every shift, not just based on their risk factors. But then developing that individualized plan of care based on the risks that we do identify is really important because we can't just do blanket prevention. What works for somebody is not going to work. We can't just put everybody gets a sacral preventative dressing, but heel offloading boots, no, or whatever it is. We have to actually look at the patient and determine what things are the highest risk for them. So like our femur fracture patients, we determine their heels are their highest risks. Do we still put sacral preventative dressings on them? Yes, but we also make sure we have heel offloading devices or dressings on those patients. Equation for success. So it's important to understand that it's not just your practice, but your products. If you have the, you know, a precise, perfect process, but the products that you are using are either subpar or they're just not indicated for the things that you're using. It's important to understand what the product's indications are and that you're using them appropriately. It's not just one or the other. You can have the best products in the world and not have the correct practice to support it. If you don't have both, then you're not going to really see those optimum patient outcomes. It takes a combination of the two. Some of the places that you can look is, pressure injury prevention guidelines. There's international, there's national, published outcomes. Like I said, other people have done the work, and I can appreciate the blood, sweat, and tears, but I also appreciate using other people's too. So, and then looking at those product resources, and then organizational trials. I have trialed plenty of things. Some things I will sit in my office, I will cut things up, I will put fluid in them, I'll squeeze them over a trash can. Is that, the pretty version? No, but I've done it. And there's no right or wrong way to really learn about the products. It's important to understand that not all dressings are created equal. So every dressing in this picture is a foam. And if you look, they're obviously all different. So when you say, evidence-based practice supports that the use of a multi-layer foam dressing, does that mean 3 layers? Does that mean 5 layers? What are these layers inside the dressings? What do they do? So it's imperative that you learn what each of those layers are. What is their job? Do they do their job? Like I said, put some fluid in it, squeeze it over a trash can, see if some fluid comes out. So does it really lock fluid in? Um, what is bonded versus non-bonded layers? So when you have bonded layers, in a foam dressing and it sits on a patient's skin, when the patient's skin slides, it slides. Those non-bonded layers are what allow for the reduction of friction and shearing because the dressing actually takes on some of that force so that it's not as impactful to your patient's skin. So understanding that is so important. Um, and then again, like I said, the moisture, I always laugh just because I really did that over a trash can in my office. So understanding that not all dressings are created equal and understanding what those layers mean, what they're meant to do, and making sure you bring the right products in. Okay, in summary, pressure injuries develop due to multiple factors, pressure, shear, friction, and microclimate. So like I said, it's not one factor. Yes, these things can all be individual, but typically they are, overlapping or in combination. It's important to understand that pressure injury prevention does not have a single solution. It's not just the products you use. It's not just the practice. It's not just the surface. It's not just the people that are there. You have to look at every aspect and not everything's going to be perfect, but looking at every aspect that impacts pressure injury development and then, attempting to improve it the best you can. That's all you can do. You can't fix everything, but just making little improvements to every aspect, and slowly you'll start to see improvements in your overall outcomes. Identifying and engaging the key stakeholders in your facility to support your overall success. Like I said, having that driving force behind you, it makes the world of difference in getting things actually motivated. When choosing your products for pressure injury prevention, the clinical efficacy is important to evaluate because not all products are created equal. All right. Thank you guys. Hopefully you enjoyed my presentation.
That was fantastic. Thank you so much, Stephanie, for taking us
Yeah.
through that. I think there's a lot of great takeaways from that. And I know we've got some questions here as well, but I'll just remind everyone on the line, if you do have any questions for Stephanie, pop those into the Q&A toolbar, and then we'll be able to get to as many as possible. I see all the hand claps and hearts and thumbs up
No, it's so
emojis. This is
nice.
great. So I know you've been talking about it, it's sort of been an overall theme throughout this here, but I wanted to see what beyond just reduced incidence rates, what other indicators do you think on your team or facility wise even indicate that prevention efforts are really working within a unit? So what other maybe it could be data points, it could be on a behavioral level. What would you say to that?
I would say, and honestly, I would say behavioral level, only because, I mean, incidence is your biggest thing that you're going to look for data wise. But one of the things that I've really noticed, and it took, I will not say the first year of change, I won't even look at it. But when I finally started seeing a change in the number of patients that I was being consulted on, or that I was just randomly finding and I was having to put the orders in for the appropriate prevention myself, that really made me feel like, okay, they finally get it. They were starting to take individual accountability into consideration, and they were putting those orders in themselves and managing that care themselves. For me, that's what I felt like really made me feel like our overall process was successful. I always say it takes at least a year to change a process. People, healthcare workers were resistant, were stubborn. So it takes a while.
Absolutely. And I think that extends down to the family and the circle of care that patients are getting to. I know we get conversations about those working in home and community care so often too that involving the family around you too to help support pressure injury prevention efforts is always so good. But there is that
Yeah,
stubbornness sometimes you get with some patients. But
for
I
sure.
we got a message in here just asking about the presentation slides. So just a reminder for everyone, we're recording today's session. We won't be sending the slides themselves, but you'll be able to watch the whole thing back again. Again, just give us a day or two. So let's say by Wednesday, end of day, we'll have it in your email inboxes and on our website as well. Alrighty, so let's go to another kind of topic here. Let's do this. I know again, I'm going to go back to the data and to presenting prevention efforts and how this can kind of change strategy here. When you're presenting data on the length of stay and cost, what messages resonate most with frontline staff to drive their change and to help really buy into that prevention effort too?
So you'll have some staff that do relate to that, that will relate to the cost, overall financial cost. But truly, I found that the bigger thing that I can get the organization, but bedside nurses for sure, to relate to is individual specific patient scenarios. So I truly, when I say this, I printed off pictures of,
Mhm.
a patient that everybody responds to pictures. I printed off pictures of a patient that came in and they were here for something else, developed this hospital-acquired pressure injury, and then had to be readmitted for a debridement and a subsequent debridement, then had to go to rehab. And when I showed them, okay, we did this to a patient, obviously not with intent, not with malice. There was none of that, but it still occurred. And could we have prevented it? Maybe. And when you show them that, I truly find that that resonates even more. Everybody can think like, oh my gosh, my grandma's been a patient here. That could have been her or any family member. So you will have some people that relate to that. But I find that, it's a lot easier to get people to relate to the true patient outcomes or how it affects a patient.
Yeah, absolutely. We're getting more and more questions coming in here, so we'll see if we can get to a few more. So we've got one about the role of prophylactics or preparing for products for pressure injury prevention ahead of time. So, what role do you think prophylactic dressings play in pressure injury prevention, and what would you recommend for preventative dressings as well, or the role of preventative dressings?
So it's truly imperative. I mean, I can't imagine, I have to say this. I'm always laughing because we have used them since before I started in this role, and I am terrified to imagine what our rates would be if our nurses did not put them on because we've had these processes in place and we apply them and we still see hospital acquired pressure injuries and they're always on the patients that they miss applying them on. So I think it is such a big deal. And tracking your numbers, the data, like I said, finding out what your numbers are right now and then implementing those. The most important one, the two highest risk or highest numbered areas that I see is the sacrum and the heels. So I think putting an easy win for us is always putting that preventative sacral dressing on a patient. That is the place that the patients lie. That's where they slide, that's where they scoot. We transfer them from one bed to another. Whatever the situation, that's just your highest risk area. And then the one that I've seen, the second most or maybe even equal truly is the heels. So whether using that prophylactic foam dressing or some kind of heel offloading device. Either way, if you're offering prevention to those two areas on any patient that's high risk. So, and that can vary. That might be a conversation for another time that I'm happy to share with anybody, but um, you will see you'll see a reduction in the number of hospital-acquired pressure injuries that you find.
Absolutely. And we got kind of like a question slash comment here. If you want to just expand on matching the product to the patient, again, not just necessarily the convenience factor or a cost factor, but being very aware of what product each patient needs individually too.
So, when you talk about product, if we're just talking about prophylactic, so looking at, I guess some of the considerations, if you're thinking about wound care or advanced wound care as a whole, so look to your wound care leaders. I've created some um, decision trees or, assessment-based treatment plans that can help the units consider what products to use. And we actually I laminate them and put them on the wall in their clean utilities so that they can see them, so to make it visible. When you're thinking about prevention, so look at your actual patient. So we have something called a turn bundle. And yes, there's this decision tree and all those criteria, but I simply say to the nurses, I'm like, if you have to walk in there and turn that patient because they can't turn themselves, then they need that turn support. So, or same thing, if you look at your patient, you're like, they're taken their, they're not able to turn off, put a preventative sacrum. If they are constantly laying, you have those ones that don't want to come off of one side, put something over their trochanter because they don't want to come off of that side. Same thing with heel. So it's truly, it really is individual because it's not blanketed. Yes, you can throw all of those measures at everybody, but that can be costly. So looking at your individual patient and identifying where their risks are is it's a good combination. You're implementing that prevention, but you're not costing everybody a fortune. So finding that middle ground.
Absolutely. We had a couple of questions here. People are really curious to see what you were doing at your facility. They're asking whether you have your decision tree or the protocol or even the role of the skin teams. Did you have that published anywhere? Do you have a poster anywhere? Is there anywhere we can point someone? Or
There
maybe that's just at your
is,
facility.
so there's a good bit of the information. There's an article in the JWOCN that published, oh gosh, I'm going to say last January. I can share that with you if you want to send it out to
Yeah, we
all.
can go after the fact.
Yeah, I
Yeah.
can do that for sure. It has a good bit of like the different interventions that we have, but briefly, um, the best intervention that I created was the term bundle, and it has preventative sacral dressing, QTR turns, wedges to help support turn. Because if you're turning your patient, but you're not turning them adequately, you're not doing them the full justice. And then ours has a repositioning reminder system, which not everybody uses, which is fine. You don't have to. And then something else in there. Oh, like our repositioning device, it helps. So if you have a 400-pound patient and you're taking one other person in there and you try to turn them, just the two of you, it's not just your back that you're hurting. You have to keep that in mind. That sheer force in using something to truly help you reposition the patient is so important. So I'd say that was probably the best thing that I
Is,
created.
is
And
that the one, the role of value analysis and pressure injury prevention? Does that sound right from January, February last year?
yes.
Perfect. Okay, awesome.
Yes.
I think I'll put in the chat in
You're
case
so
anyone's
much
interested
quicker
in
than
doing some.
me.
Well, just in case anyone wants to quickly check here, but maybe we'll follow up after with that one in the email.
Yeah.
But yeah, thank you. Yeah, that's a huge show. I'm glad you published on that. Fantastic.
And then implementing it, if you guys use electronic
Yeah.
medical record, if you tie your preventative, nurses are busy. We have to account for the fact that they're busy and that they're not going to remember everything every time. So tying your orders together and tying them to the electronic medical record really made a big difference for us.
Absolutely. Well, I think that's a fantastic point, and I love when we have a nurse speaking about nurse roles here, because I'm sure there's a lot of people in the chat who are saying thank you so much, and you're speaking my language here.
I
Uh,
love that.
Maybe one more, and we're coming up to the hour here, but I know we had a question that came up at one of our other pressure injury prevention webinars a little while back, and some people were still just having a bit of a difficulty with separating what's moisture associated skin damage sometimes, especially in the sacral area, or if we're looking at the buttocks or something like that versus a pressure injury? What are maybe some of a key sign that might be one versus the other?
The two easiest ways to identify it, so I teach my nurses at the end of the day, if it blanches, it's not pressure. I don't care. There's been times I look at the picture before I walk in a room and I'm dead set that it's going to be pressure. And then I walk in there and it blanches. And I'm like, okay, it's not. So if it's pressure, it will not blanch. If it blanches, it's something else. And the other thing that is very common with moisture associated skin damage is mirror image things. So if they
Hmm.
look like their butt's fine and this is gonna sound funny, but if you spread their butt crack and it looks like a fire engine because it's on both sides, it's moisture. You know, when you have those mirror image lesions where it rubs in the same spot, those things are all indicative of moisture. And at the end of the day, if it blanches, it's not pressure. Easiest way.
Perfect. Well, thank you for that extra tip at the end there too. I know we're at the hour, so I want to say thank you again, Stephanie. It was so awesome having
You're
you
so
out on
welcome.
today. Presentation was so great too. And I'll just do a couple quick final reminders for those who are still on. As I said before, you're going to be receiving a certificate of attendance. We'll send a post-webinar email before end of day Wednesday that'll have the recording for today's session. It'll have your certificate. We'll give the links to Stephanie's article. And then we got a little bit more resources to learn from there. But thank you to Smith and Nephew for making today possible. I know it won't be the last time we do an educational webinar with Smith and Nephew, and you can see my background here potentially on Zoom. Just a reminder that we do have our WCET and NSWOC joint congress coming up at the end of April here. If you're already coming, we can't wait to see you there. Smith and Nephew is one of our platinum sponsors, so you can always go and check in, say hi to them on site in Vancouver. If you're not going to be there this year, that's okay. We hope to see you next time. But either way, we'll see you on another webinar coming up soon. And Stephanie, we hope to partner with you again.
Yes, thank you for having me.
Have a good night, everyone.